so around 210,000 valve operations are performed worldwide. And paravalvular leakage is an uncommon but yet a serious complication of these prosthetic valves. And you can see it in 2 to 10% in aortic valves and 7 to 17% in mitral valve, but of course not all severe. In TAVR, we still see it as well. It was higher, but it's decreasing. But also it sometimes comes now with pacemaker rates, so you always, in TAVR, you have to make the decision to over or undersize. So 1 to 5% of these patients with a PVL are symptomatic, and what they present with, the majority will present with congestive heart failure, and around 70% will have a NIA class above 3. Some will have a hemolysis, and 60% of these cases will be evident in the first year. And we know what are the reasons. So there can be an infection, there can be alveolar calcification, the tissue can be friable or weak at the site of suturing, and of course also the surgeon can do wrong job or technical factors at the time of implantation. And a PVL may be associated with hemodynamically significant regurgitation causing heart failure or hemolysis, and a reoperation is associated with an increased likelihood of recurrent leak. So, and also reoperation has quite a high morbidity and mortality, which can go up to 22%. There are several ways to operate these kind of valve, and you see the more reoperation you're going to do, the mortality rates really increase, and that's why a transcatheter way of treating these paravalvular leaks is appealing. But we have to keep in mind that there are at the moment a limited amount of devices available, and the anatomy of the defect frequently is crescent or regular shape, doesn't completely fit with the devices that are really available nowadays. And even small hemodynamically insignificant residual leaks may cause hemolysis. So you can have a technical success by closing off the leak, but still this small leak can cause hemolysis, and it will be a medical failure for the patient. And I'm from the Netherlands, so we have a lot of dikes. So there's a big story about Jan Brinker putting his finger in the dike to save the land from flooding. So that's something we have to do. We have to stop the leak. And if we look at the plugs that are being used, a little bit depends on which part of the world you are. There are several devices. So frequently the Emplatzer plugs are used, and or ASD, ADO, it doesn't really matter. Several plugs can be used. For us, it's most of the time the AVP-free plug, but not everywhere in the world there is approval for this plug. And there is this specific designed Occlutech device for paravalvular leakage. Personally, I find this one quite rigid and not always covering the complete PVL. But again, as already said, the PVLs are frequently crescent-shaped, and the plugs we're going to put in are frequently round. So at the edges of the PVL, you frequently see borders when it's not completely covering. So you're putting a round plug in a crescent-shaped hole. Echo is really crucial before the assessment of the PVL, and both TE and ICE can be used during the procedure, but nowadays frequently free TE is used because it's preferred, because it's nicely can show you the irregular shape, the crescent shape, and if there are multiple defects, even much easier than with 2D, and can provide accurate sizing of the PVL. But if you look at it, echo in general, it can be technically demanding. We already discussed it because of the shadowing of the prosthesis, especially when we're going to use transthoracic. It can be difficult to visualize PVLs on the mitral side, but we're looking for actual areas of dropout which can be detected, and of course if we put on the collar we'll see color flow coming through this defect. And we have with all the procedure we're going to do, we need a clear communication with your interventionist where the leak is located. So this is one, it's a little bit like the one I've shown before, but again, sometimes with the transthoracic images, it can be difficult to find the PVLs, especially with mechanical prosthesis to find, and this is less a problem with the aorta regurgitation, which is much easier to see with transthoracic echo, but the PVLs with transthoracic, again, you see something going on over here, but a big defect you're nicely showing with the TE is frequently much easier to be seen with TEE. So we need to have a clear communication. So frequently with the interventions, we're going to put the aortic valve on top, and that's what we call 12 o'clock. And then we have the septal side around 3 o'clock. We go to posterior around 6 o'clock, and we have the LAA side looking from the mitral valve above, which is around 9 o'clock. And that's the way you communicate. And I already discussed it in the previous talk, but if you do an examination for a PVL, keep your probe stable and completely do a sweep around 0 to 180 degrees and make an image every 10 degrees and try to find out where there is a dropout, and where personally I always use color compare, where I see the dropout and if I see the color, and I put in the report how many degrees there is the defect, and then I go to my 3D and do the measurements as well. So just to show you how we do this, so I'm not moving the probe and I just go completely around, and we can see with this we have a very large leak before the procedure. So and this is how it looks like. One of our previous procedures we have done, a very large leaks completely going from 9 almost to 6, so a quarter of the valve is completely loose. It was a patient which was inoperable. You nicely can see it in the still images here as well. And if you want, we can do the sizing with 3D as well, and we can use our 3D volume with color, try to minimize the box as much as possible to get higher frame rates. Nowadays with the newer probes it's getting less and less of a problem, and then you start cutting into your 3D examination, and for this it looks like one big leak, but the more you cut in, you can see there are actually 2 leaks that are separated from each other. And just to show you how to measure, so we have a 3D data set with your leak, and again we're going to crop in. You see 2 leaks are actually here, and with this, hopefully it works here as well, we're going to align our MPRs and make a nice en face view of the paravalvular leakage, and this we can trace completely and have an idea what the maximum, minimum diameter and the average diameter are, and based on this we're going to decide which plug we're going to place. Let's see. So again, putting in your lines nicely perpendicular plane, and then you have an en face view where you can nicely do the circumference, you can do the area, you can do all the measurements you need. So, and if we move on to the procedure as well, TE is also really necessary in that we need to confirm the location, we need to confirm the severity, and during the procedure we want to exclude thrombi or vegetation. We want to make sure if there is a device placed that we are not interacting with the prosthesis itself, if there is residual leakage, and if we see any complications during the procedure. But more and more in our center as well, we are also using to plan our procedures with CT, because we have fantastic imaging with CT. We have a high spatial resolution of the scan. If we do it in multiple phases, we can have excellent imaging of, and where you nicely can see the defects as well, and have a nice measurement before. And a nice thing, and I cannot go into detail on this information with the heart navigator that was previously shown, we can use this during the procedure to help our interventionalists to do the procedure. So just to show you here, we can see the length of the tunnel, we can see the width of the tunnel, and just to show you a little bit, nicely showing here the use of the CT, and again the segmentation which we know from the heart model. On the EPIC machines we can segment the machine, we can segment the prosthesis, and we can simply visualize where the leakage, and we can mark this spot. And the nice thing now is if we use the information, we can highlight the ribs, and we can find the best place. And in our center we do most of the procedures transapically because it's shorter. We have much more push to get to the paravalvular leakage. We can plan our procedure completely, showing where to enter the at which rib, to avoid puncturing the lung, to avoid puncturing the LAD, just to go in, and we can play with the different plugs. Just to show you shortly in the next one, with the overlay, we can have the ribs, let's see, laid over, and we really have our marker and path of the needle where we need to go to enter into towards the PVL. I'm not going to show you the complete case. But I think fusion imaging, and we haven't discussed that as much today, but fusion imaging is really helping with these kind of procedures. We simply can use your echo information and project this on our fluoroscopy. So we can highlight the spots with the old echo navigator system. We can do an annotation, just mark the spot on fluoroscopy. You say, hey, this is where the paravalvular leakage is. Put your wire over here, And with the newer versions of the Echo Navigator, we can have real live overlay. We can simply put on the collar and the interventionist can see at one screen the fluoroscopy and where the leakage is completely. So we can mark the spot, and you can see here we're nicely aiming for the position there are plugs. Also discussed a little bit before, we have different approaches to do this. We can do this transeptally. Frequently, this has the limitation if you really have to go to the medial side. It's difficult to cross these leaks. You can go retrograde through the aorta, but again, a lot of bends have to be made. Or you can go transapically. And in our center, we prefer that in majority of the case because we have a lot of force and a lot of strength to put in the plugs. And the nice thing, if we go transapically, we can put in multiple sheets and deploy several sheets at the simultaneous time. This is also one of our cases just to show you how 3D nicely can help you to determine where the leakage is and how big it is. Oh, sorry to go back. We can see the leakage on 2D and this clear, nice, round, actually this time, PVL. And also this is where the color is coming from. I must say this is, as you can see, it's from 2009. In the beginning, the interventions didn't believe it was just that nice, the images, because the nice round hole, but it really was where exactly the color was coming from. And during the procedure, again, we can help to find the interventionist to find the right spot for the transapical puncture, and then help them to guide them, the wire, through the PVL and look from above, and we can see the deployment of the plug. And this is one of our first cases. We can see the plug is over here. And again, this is also the same. There is a crescent-shaped, a little bit point over here, where there is some residual leakage left. One interesting case, I think this was one of our most interesting cases. We had a 54-year-old female, North African. 2001, she had a mechanical aorta prosthesis and a mitral prosthesis due to rheumatic heart valve disease, had a reoperation, and again a perimount bioprosthesis was placed, and also in the mitral flow was placed in the aorta position. Both procedures were carried out, but then she was initially doing very well, but 2 months after the procedure, she was in cardiogenic shock and pulmonary edema secondary to a significant mitral valve paravalvular leakage, and she was transferred from another hospital to our hospital because they were trying to wean her from inotropes. They were trying to wean her from the ventilation for a very long time, and every time if they were close, he completely fell back. So he's on the ICU, I think, for almost 6 weeks. And it was unsuccessful to get her off, so they referred her to us, and we discussed her, and of course it was not redo operation. In this condition, it had the Euroscore 2 of 47% of dying, so it was a really high risk. So at that time we decided for this patient to do a transapical approach. And again, we have seen this, but again, a huge leak can be seen. Almost quarter of the valve is loosened. And now we can help the interventionalist again. It's easy to pass, of course, with this leaks, the paravalvular leakage. So the first plug is deployed here, and then the wire is positioned here. Second device is placed. And now if you look before and after the procedure, it's clear. This is before, almost none, before, almost none. And if you continue, you can see we almost completely got rid of all the paravalvular leakage. You can see this is before, and only a trivial jet between two plugs in the 3D images. So I think very nicely the procedure, and the nice thing at the end of the procedure, she was rapidly weaned from all inotropes, vasotrappers, and diuretics, and she was extubated the same night. So what they couldn't do 6 weeks before, we just after the procedure could do in one day, and actually the next day she came walking into our echo lab without having any problems. So I think a life-saving procedure. So finally, to end up with, we have to look, of course, also for complications. So here we can nicely see an interference. If I get my mouse, I don't see it, but we can see an interference on the left from a big VSD device with the disc. And of course, we also have to make sure that we do not see embolized, or this is just to show you how it looks like. So with mechanical valves, also try to really push back the devices to their neutral position, because sometimes you have a tension on it and it looks okay, and if you release them, the device gets back and you will still have interaction with the valve. And furthermore, what you really, of course, also want to prevent is that you have these flying saucers in your left atrium going around, because then you have to snare them and get them out. It looks nice, although you see them, these UFOs going up around, but it takes quite a lot of time to snare this and to get this out, especially with the mechanical valve. So to end up, a PVL is an uncommon but yet a serious complication of prosthetic valves. Peri-procedural imaging is crucial, and I think especially 3D is now the preferred modality. We have to do an entire sweep around the ring and keep your probe still, and we can use MPR for sizing of the PVL and to decide which device we are going to implant. Thank you very much.